much. Actually, afternoon when I came inside, I was trying to look for any space to sit. Hall was full. But recently, the தேர்தல் நடந்துச்சு 85% votingலாம் பேசிட்டாங்க. They gave about 1,500 to 3,000 rupees per vote எங்க ஏரியால. இவர் எவ்வளவு பணம் கொடுத்தாருன்னு தெரியல, எப்படி இவ்வளவு பேர் உள்ள இருந்தாங்க. And Sundar every time present பண்றப்போ dairy milk கொடுத்துட்டு இருக்க எல்லாம் diabetics they are talking about sugars. So
Sir,
next time you should bring
definitely they were not bribed. It's all our stalwart speakers, and that's what it is.
Yeah. That's what I'm saying. அன்பை அந்த அளவு அன்பை கொடுத்துட்டு வாங்கியிருக்கிறீங்க. So next time rather than dairy milk, you can bring a small sachet of nuts. So that will be a healthy message also. Okay, right. So we'll go to this topic. It's going to be a very simple, small topic. It's only for 10 minutes. Thereafter, we're going to go for our coffee and tea. Diabetes and heart failure is a two-way street. So diabetes is the CVD equivalent. So from the point of view of cardiovascular disease, it is appropriate to say diabetes is a cardiovascular disease. AHA scientific statement, it came in circulation 1999. Now, diabetes is equal to stage A heart failure. So what do you mean by stage A heart failure? Stage A is something where you have a predisposing factor for heart failure. Stage B is there is some element of heart failure but subclinical. Stage T is clinical heart failure. Stage 4 is heart failure at rest. So if somebody is having diabetes, that means he has every reason to develop heart failure at some point of time. That's why it's called as stage A heart failure. So let us come to this case. It's a real case. 57-year-old male, known diabetic for was 8 years, no other conventional risk factors. Of course, age is additionally one more risk factor. Presence with breathlessness for was 1 hour. No history of chest pain. He is tachypneic. Saturation at admission was 86%. JVP normal, no leg edema. So what do they mean? It's not a right heart failure. It's not a biventricular failure. It's a pure left ventricular failure causing pulmonary edema. Pulse rate 90 per minute, regular. Blood pressure was 180 by 100 millimeters of mercury. And there were bilateral region crepitations. So with this clinical history, one would easily diagnose accelerated hypertension with pulmonary edema as the basic diagnosis. Now, this is the ECG, which is initially immediately available on the bedside. So the most important cardiac investigation which is easily available is by ECG, and it is 110 years old. It has not lost the relevance, and the kind of information what we get by ECG cannot be equated by any other investigation. Now, this shows obviously left ventricular hypertrophy and left is LV strain pattern. So at emergency room, non-invasive ventilation was done, furosemide infusion was started, and nitroglycerin infusion was also simultaneously started. So what about his blood chemistry? Now he is under treatment, he is slowly improving. Meanwhile, we get the blood chemistry. Sugar is 360/46. NT-proBNP is very much elevated. Troponin I is also elevated, 86. Urea was 78, creatinine 2.2. Okay. See, he has high urea creatinine, he has high troponins, he has high NT-proBNP, he has high sugar. So plain bolus insulin was given and subsequently infusion was started. Now at this point of time, once the blood investigations were available, non-STEMI was diagnosed. Non-ST elevation myocardial infarction. Why? He has troponins elevated and this ECG showing STD changes. This ECG is more of left ventricular hypertrophy than ischemia. Those who repeatedly see, they can understand. This kind of downsloping ST and ending with T inversion is more of a left ventricular hypertrophy than a horizontal ST depression and T inversion. And whenever there is ischemia, generally we don't have associated tall QRS complexes. So the tall QRS complexes, downsloping ST and T inversion is more of LVH. But still, in non-STEMI was diagnosed. 4 hours later, what has happened? Now patient is settled. NAV was changed to mask oxygen. He poured out about 2.3 liters of urine. Now the blood pressure is 106/70. That made the nitroglycerin to be tapered off and stopped. By the time echo was done, echo showed constant left ventricular hypertrophy, no regional warm motion abnormality, good LV function, no valvular pathology. Okay. Now, do we need to revise our diagnosis? Why am I bringing this line now? Do we need to revise? Our original diagnosis was accelerated hypertension with pulmonary edema, right? Now, do we need to diagnose? So coronary angiography was done next day. It was showing a left dominant system. There were 30% lesions in mid-Delirian last OM branch and no evidence of acute plaque rupture. So let us refine the diagnosis. Is there diabetes or not? Undoubted. There is no question about the diabetes. What about hypertension? We recorded 180 over 100 admission, isn't it? So his BP decreased to normal within hours of controlling pulmonary edema. Hence, the systemic hypertension was secondary to the increase in the sympathetic drive associated with pulmonary edema and not the other way. Whenever somebody has hypertension, and if it develops accelerated hypertension or acute increase in hypertension, that can induce pulmonary edema, right? That's a very definite diagnosis. But in that case, once you manage the pulmonary edema, clinically he will improve, but the BP from 180 would have come to 160 and 150 and stay there, it won't come to normal. Okay? So, accelerated hypertension related pulmonary edema will improve with medications, patients will improve, but it will take us for 2 to 3 days for the blood pressure to come down to near normal levels. Whereas here, the moment to control the pulmonary edema, BP drops to his original BP. The original BP was normal. So he was not a hypertension. So he was not a hypertensive individual, basically reactive systemic hypertension secondary to the pulmonary edema. Now what about non-STEMI? Mild increase in troponin is common with any form of heart failure. More so in the background of elevated renal parameters. So morning we had a discussion of insulin therapy. You all know that whenever there are renal parameters are elevated, insulin clearance is reduced and the need for insulin therapy comes down. Similarly, the troponins are also cleared by the kidneys. So whenever you have renal parameters, troponin clearance is reduced and troponin elevation is common. But it remains in the same slightly higher level. There won't be continuous elevation in the troponins. So whenever we have doubt in such a situation, we should repeat the troponins 4 to 6 hours later, and this will be at least 20% increase from the basal level for us to diagnose ongoing muscle damage, ongoing continuous increase in the troponins. One time high elevation of troponin, about 2 to 3 times the upper limit, can be normally seen in the presence of renal disorders. So we can take out the diagnosis of non-STEMI, we can take out the diagnosis of hypertension. So we are left with only diabetes mellitus, which is presenting us heart failure. So what is the diagnosis now? Diagnosis, heart failure with preserved ejection fraction due to diabetic cardiomyopathy. So this is a very classical case. So how do you diagnose diabetic cardiomyopathy? Patient has diabetes, LVH, and there is no CAD or hypertension. What's that? Yes, that's what I'm saying. ECG is very much. No, concentric LVH can be there without hypertension and diabetes. That's what I'm trying to say. In patients with diabetes, there can be concentric LVH without hypertension. That is because of diabetic cardiomyopathy. That's one of the known features. That's why I wanted to bring this point. So presence of normal. So presence of LVH automatically doesn't mean it was secondary to hypertension. In the absence of hypertension also, diabetics can have LVH. Okay? So when it comes to heart failure with preserved ejection fraction, we have multiple reasons. There are multiple reasons, and diabetes is a very important reason. So sleep apnea, chronotropic incompetence, systemic hypertension, obesity, elderly persons, iron deficiency anemia, all can present with heart failure preserved ejection fraction. One simple clue or very easy diagnosis made bedside is the echocardiography. Now here you can see the inverted image. The lower ones are atria, upper ones are ventricles. There is left ventricle hypertrophy. There is also right ventricle hypertrophy and the atria enlarged. If you see the atria enlargement, the atrium, the sizes of atria are much more than the size of even ventricles because of the restrictive inflow. Whenever there is a restriction to the flow, this chamber increases in size. So this causes heart failure with preserved ejection fraction. What will be the other one? Heart failure with reduced ejection fraction. The left ventricle is very much enlarged. Left atrium is mildly enlarged compared to right atrium, but it is mildly enlarged, but left ventricle is very much enlarged, and there is uniform hypocontractility causing heart failure with reduced ejection fraction. This is based on the 2D evaluation. One important understanding regarding the MO Doppler, it's not very difficult to understand. Now, you know, the mitral valve is closed when the patient is in systole. When the heart is in systole, the blood is ejected into the aorta, mitral valve is closed. Now heart is trying to relax now, it's coming to diastole. What will happen to the early part of diastole? The mitral valve opens. Whatever the blood was there in the left atrium suddenly enters into the left ventricle. So there is an early diastolic phase. Phase 1, this is A. So early diastolic inflow, we call this E wave. There is when the moment mitral valve opens, passive flow of blood which was accumulated in the left atrium will come to the left ventricle. That is early flow, E. Then what happens? Near the end of the diastole, atrium contracts. So before the next systole, near the end of the diastole, atrium contracts. some more amount of blood into the, from the left atrium will enter the left ventricle. That causes A wave. This is A wave. This second one is A wave. So this atrial contraction related flow, this early diastolic flow. We have E wave, A wave. E is more than the A. Because the left ventricle is very compliant. When the left ventricle is compliant, when the mitral valve opens, the blood easily enters in the left ventricle. So the initial flow is very high. Subsequently, you have lesser amount of blood in the left atrium. Our atrium has to contract only minimally, and you get another wave called A wave. So we have E wave and A wave. What happens when the left ventricle compliance decreases? Now, because of the reduced compliance in the left ventricle, the easy initial flow doesn't occur. The flow occurs, but to a lesser extent. But thereafter, atrium has to contract much more powerfully to push the residual atrial blood into the ventricle. So it reverses. Now, E becomes smaller and A becomes taller. So this is what is called a EA reversal, which is very commonly seen. Anybody who is having, who undergoes an echo more than 50 years, they will find this EA reversal. They give us a grade 1 diastolic dysfunction. So people are really worried about what about this grade 1 diastolic dysfunction. Generally, it is benign as long as it doesn't progress to subsequent levels. Now, what has happened here? Here you don't see two waves. Both E and A waves are fused to E and A waves. So this indicates grade 2 or grade 3 diastolic dysfunction. This is one easy way of understanding the diastolic dysfunction. Okay. So with this topic, with this background of having seen a classical patient who presented with pulmonary edema, with diabetes as the only background, let us go to this topic, diabetes mellitus and heart failure. So diabetes mellitus and heart failure are global epidemics. DM increases heart failure risk and heart failure worsens glycemic risk. So it creates a vicious cycle. DM increases the heart failure risk by 2 to 5 folds. It frequently coexists and amplifies each other's risk and severity. 30 to 40% of heart failure patients have diabetes. Heart failure prevalence in diabetics is 9 to 22%. The relationship is bidirectional and pathophysiologically intertwined. Let us just see shortly. As you can see here, at any age beyond 45, at any age, non-diabetic individuals are given in red and diabetic individuals are given in blue. The incidence of heart failure is much higher in diabetic individuals compared to non-diabetics at any age. And as is mentioned, it's a two-way road. Diabetes leads to heart failure leads to diabetes. All these are common background which is affecting the both. So what are the mechanisms by which heart failure causes diabetes? It worsens insulin resistance. Because of the reduced perfusion and increase in the sympathetic nervous system and renin-angiotensin activity leading to insulin resistance. There is organ hypoperfusion, so pancreas and liver dysfunction results in impaired glucose metabolism. There is increased inflammation. As we all know, most of the cardiac diseases are linked to inflammation. Even in heart failure, the so-called cold, stable heart failure, there is some element of inflammation going on. So increased inflammation and cytokines cause insulin resistance and beta cell dysfunction. And it could be drug-induced, like older beta blockers, not the current ones. Thiazide diuretics and steroids all can worsen the diabetes or induce the diabetes. So what diabetes does to the heart failure? So diabetes causes metabolic derangements, as we know, insulin resistance, and it shifts the free fat it shifts from glucose metabolism to the free fatty acid metabolism, leading to local lipotoxicity. There will be also glucotoxicity related problems due to glycase and end products, which promotes fibrosis and stiffness. There will be oxidative stress and inflammation. All these are various mechanisms, endothelial dysfunction. And autonomic neuropathy, as he has rightly said, autonomic neuropathy can kill the patient because of the impaired heart rate variability and increased arrhythmogenic risk. And obviously there is RAS and SNS activation. So there is a mixed pathophysiology, as I have seen here. This can lead to that, that can lead to this, and both will worsen each other. The heart failure phenotypes, as I have mentioned, it could be heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. Majority are heart failure with preserved ejection fraction, but diabetes mellitus can contribute to the worsening or progression of the heart failure with reduced ejection fraction. So diabetic cardiomyopathy, we should understand, is a distinct clinical entity where there is abnormal myocardial performance or structure in the absence of epicardial coronary artery disease, hypertension or significant valvular heart disease. It was first described as early as 1972. Both systolic and diastolic dysfunction can occur. So it starts with diastolic dysfunction and can gradually progress to systolic dysfunction. Biventricular dysfunction will occur at the end of the spectrum as a part of diabetic cardiomyopathy. The early changes are only in diastolic dysfunction, and if you carefully analyze the echocardiogram of a diabetics as much as 70% can have asymptomatic mild form of heart failure. When somebody comes with, see the third line, when somebody comes with fatigue, weakness and reduced exercise tolerance, we commonly blame to so many other reasons, age, probably you're not exercising, your body has not adapted and things like that. But this fatigue, weakness and reduced exercise tolerance can be a mild form of heart failure with preserved ejection fraction. It can be a mild form of pulmonary edema which is not clinically detectable. So we have to think in this angle, and at times this can be so bad that can present with arrhythmia or even sudden death. So as we all know, SGLT inhibitors are game changers. This topic would have been discussed at least 100 times in the past 2 days, so I'm just skipping this slide. There are 4 pillars for heart failure with reduced ejection fraction. Okay, beta blockers, SGLT inhibitors, MRA and ARNI. In the beta blockers, we have 3 very important beta blockers, carvedilol, carvedilol, bisoprolol and metoprolol. In the SGLT, we have empagliflozin and dapagliflozin. In the mRNA, we have eplerenone or spironolactone. Of course, RNA or ACE. And whatever we have given the yellow are 2B indications. The green are all class 1 indications. The yellow are all class 2 indications, 2A or 2B indications. We are not going to go through that. So 4 pillars of heart failure with reduced ejection fraction, everybody remembers. And what about the treatment for heart failure with preserved ejection fraction? Obviously, diuretic is the answer. Do we have any MRA which has been shown to be effective? Yes, it's not spironolactone, but if it is finerenone. Morning there was a discussion on finerenone, especially the management of diabetes in CKD patients. There also he emphasizes on finerenone. So the MRA which we have to use in patients with heart failure and preserved ejection fractions, finerenone. ARNI also has been shown to be slightly beneficial, not very beneficial as in case of heart failure with reduced ejection fraction. And the 4th pillar, very recently added, is a semaglutide. Okay, semaglutide, he did mention about FLOW trial. I don't know whether you observed or not. There is a trial called FLOW, where injection semaglutide has shown to reduce the renal outcomes in patients with diabetes. So the 4 pillars for heart failure with preserved ejection fraction are, there is no beta blocker. There is MRA, finerenone, there is ARNI, okay, there is semaglutide, and of course there are some SGLT inhibitors at the top, because SGLT inhibitors was the one initially accepted. So these are the 4 treatments for heart failure with preserved ejection fraction. So what are the impact of heart failure drugs on diabetes? ACI-ARB improve insulin sensitivity. Melanocortin receptor antagonists, again they have a lot of metabolic benefits. SGLT inhibitors, they help both diabetes and heart failure by multiple mechanisms. It is the beta blockers which you have to be careful. We should be using the selective agents. So when you compare, when you go to the selectivity, the best selectivity is there for nebivolol, bisoprolol, and then metoprolol, and then carvedilol. So if you go with the selectivity, one can stick on to carvedilol or bisoprolol and nebivolol. Carvedilol is slightly non-selective, metoprolol is slightly non-selective. But they also have been found to be beneficial in pure heart failure, but in diabetes with heart failure, it is better to use the first 2. Better to avoid come to the caution, the one here, Dr. SMS also showed an example where thiazide causing erectile dysfunction as a side effect. You know, thiazide can cause worsen the glucose tolerance also, as I mentioned here. So all these beta blockers we have to be careful. In the other drugs, we have to be careful on diuretics. Okay, so these are the various effect of anti-diabetic drugs on heart failure. SGLT inhibitor is very useful. GLP-1 receptor antagonists also have cardiovascular benefit. They also have modest effect on heart failure. Metformin is safe and neutral. Thiazolidine ions cause fluid retention and can worsen the heart failure. Saxagliptin has been shown to increase hospitalization risk, and insulin also can cause sodium retention and worsening of heart failure. So these last 3 drugs, we have to be slightly careful if the patient has a history of heart failure, whereas other 3 drugs are very beneficial. Okay, so integrated management, it cannot be only diabetic management, we have to treat the patient as a whole. So the message is, diabetes is equal to stage A heart failure. Screen for heart failure in all diabetics. Symptoms, as I mentioned, the mild symptoms, what you thought may be negligible symptom, can be actual evidence of early heart failure. Do BNP, do echo when indicated. Screen for dysglycemia in all heart failure patients. Heart failure with diabetes is equal to very high risk phenotype. So we have to have aggressive treatment in this group of patients, and we have to treat both conditions simultaneously for best outcome. Thank you very much. Thank you.